Hello, everyone, and welcome to our training today. We really appreciate your attendance and interest, and thank you for taking the time to learn. We've got some great information today, and what you're seeing on your slide is this is an industry topic. So about once or twice a month, usually on Wednesdays, we'll get some experts bringing some of that newest, greatest information to you. And today, as you can see, we have our guest speaker, Hugh Heaton. So I'm really excited for Hugh to present some information for us today. Before we get started, I want to just take a moment to go through some kind of basic housekeeping items. As you'll notice here on this slide, the GoToWebinar panel, we want to make sure that each and every one of you are comfortable with asking questions. So if you can take a second, find that little questions line and click on the little arrow, then the number 2 screenshot will show where when you click on the arrow, the question pane opens up, and you'll simply click your question, put it in there, click send, and there's a panel of us here that are moderating and watching those questions, so you'll see one of us answer those questions throughout today's training, and we'll save some of those great ones for the end also. So the next slide, for those of you that are not aware, I think many of you are, but we've got some great news. During the craziness of 2020, Team TSI was actually purchased by SHP, which is Strategic Healthcare Programs. So we've been going through some wonderful changes, and one of the things that you'll see coming soon is the Team TSI logo start to kind of disappear a little bit in that SHP. You'll see that starting to come through in emails and colors and things like that. So one wonderful thing to know is the IntelliLogix program, in which many of you are using and familiar with, will simply take a little color change, but the system is that same great quality, the same commitment from the team, and the same wonderful support team. So in case you weren't aware and you start to see SHP, it's that same IntelliLogix system. So the last thing I want to just give a moment to those of you that are not our customers, and looking at the attendee list, I'm really happy that so many of our customers are on. But if you happen to not really know what type of services we provide and you're interested in those services, we are happy to reach out and give you some additional information, or maybe even provide a demonstration. So please feel free in the chat box or in the question box to ask us for more information. And for those of you that are not subscribing, we'd be reaching out to you with a demo and our team to get you that information. So with that, I want to introduce our wonderful panel today. My name is Dahlia Croft, and I am simply the one that is going to hand you to these amazing experts. You'll see a number of names here, and first of all, our team, Greg Seipel and Pat Newberry, they're your everyday experts that are working on the system, those improvements, working with our development team. And if you've ever worked with them, the wealth of knowledge is amazing. And along with Hugh Heaton, he is one of our experts, is kind of our go-to expert. And I love to hear actually some of our team talk about Hugh and just the years of wealth that he's brought to each and every one of us through his wisdom. So with that, I'm going to turn this over to our team, and know that Kelsey Cherico and myself, you'll probably see our names on those questions and answers. We're all here to help and support you, and also our support team at support@teamtsi.com. So with that, I'll turn it over to you. Thank you.
Hi, thanks so much, Dahlia. Just kind of wanted to go over what some of the focus is of today's session. There's a very famous quote by Mike Tyson when he was the former heavyweight champion of the world that says he was known as saying, everybody goes into a fight with a plan until they get punched in the face. And I think everybody started the year 2020 with a strategic plan on what they hope to accomplish in that year, whether it was going to be financial or quality goals. And then, of course, COVID kind of came out of their side of the ring and punched everybody in the face really, really hard. And everybody's strategic plan sort of went out the window. So everybody's more or less kind of had to adapt at a really accelerated pace for everything that's changed, not just changed in the way we live our lives and how we socialize and coordinate with each other, but the significant changes that impacted the long-term care industry and skilled nursing. So part of the
I lost Greg. Hello?
I'm so sorry, I'm back. I must have clicked the wrong button, or somebody might have clicked me, but I don't have the ability to advance the slides is what I was saying. Oh, there we go. Okay. So what we're trying to accomplish today is, we've had this kind of evolving and ever-changing landscape in our industry, more so than anybody else. I heard the head of one of the other larger healthcare chains out there make a statement early on in the pandemic that a death that occurs in a hospital is a statistic, and a death that occurs in a long-term care facility is a news story. So we've always been under a different level of scrutiny and oversight, not just in the media, but in the General Accounting Office and the OIG investigations and state agencies and the surveyors and CMS, and there's always been that. And of course, when you start to see a high number, anywhere from 40% or higher of the COVID deaths occurring in long-term care facilities, it's going to raise some scrutiny. Well, with that came some survey tags. We've sort of dealt with these as the year's gone on. There might be a couple that have slipped past you weren't aware of, but what we're going to do in today's session is kind of identify and discuss those recently added survey tags. We're also going to look at what the changes they've made in the revised survey entrance form, what they're looking at when they, what they're asking for when they first walk through the door. There's things they want in the first hour, the things they want immediately upon entrance, and that list has changed to accommodate and adapt to the pandemic and COVID-19. We're also going to go over, kind of review and discuss the revised infection control critical element pathway. The questions that are going to be asked, that the surveyors are going to be reviewing, the types of information, how heavily it's weighted to training and competency. And we're also going to look at the revised long-term care survey process and procedures. One of the things is going to be the resumption of standard surveys. And we've got some inside information possibly on the methodology that might be employed with that to a certain extent. And then of course, we're still operating under a public health emergency. So we still have the 1135 waivers. Certain elements of tags, survey tags, are waived, but not the entire tag. So when they waive certain requirements in a public health emergency, that has impact on different areas of different tags, but it doesn't excuse or release anybody from the entire responsibility of that tag. And that's really a really vital and significant thing to understand, is that, oh, well, I don't have to worry about this tag. Well, you do, you just don't have to worry about this portion of the tag. And we're luckily joined by Hugh Heaton today. And if you recognize the name, as I'm sure many of you do from the Heaton manuals, Hugh has been around probably more years than he'd care for me to mention, but has sort of been a presence in this industry for a significant amount of time, very long time. Well known for writing the policies and procedures that many of you utilize and employ in your everyday practice. I've never met somebody more connected to the regulatory process in different state agencies, and that devotes so much time, energy, and resources to education and training to keep everybody up to date on the industry. So with that, I'm going to turn it over to Hugh, and we'll start working through the session goals. And then, of course, Pat Newberry and myself will be adding in any information that we can share. So Hugh, please take it away.
Thank you, Greg. Good afternoon, everyone. It's a pleasure to be with you. First thing I want to do is for us to look at the handouts. Just spend a few brief moments on looking at that. Handout number one is a session presentation outline. This is it's designed so that you can take notes. It's the exact slides that you'll be seeing as we go through the presentation. And feel free to download it and use it, and maybe as a follow-up in providing information to your facility staff as well. The main handouts we want to look at is this one. These are handouts numbers 2 through number 6. It's 119 pages, but it's you'll find them very well bookmarked. But I want to take just a moment to go through them. Each one of these handouts will be discussed through the session. For example, the recently added survey tags. What you will find is as you click through the handout, you will find a listing of all of the survey tag numbers that we're going to look at. So everything is here for all of the newly added survey tags. Handout number 3 is your revised survey entrance conference forms. When you open that up, you'll notice that it says that all the revisions are identified by red text. So when you look at the entrance conference form, this form was updated in November of last year. All of the red numbers have been added. If you're familiar with the Focused Infection Control Survey, you will find that these come directly from the Focused Infection Control Survey entrance conference form. And what CMS has done is they've taken the two forms and combined them into one. So you will no longer have just a Focused Infection Control Survey process that's not using some of the other data. It's all combined into one survey now, as we will go through and look at that. Handout number 4 is the new Focused Infection Control Critical Element Pathway. And what CMS has done with that, enlarge that just a little bit, they've taken the Focused Infection Control Critical Element Pathway and the Infection Control Pathway and combined them into one. So this will be used for Focused Infection Control surveys. It will be used for standard surveys, complaint surveys. Everything will be used in this one particular document. And as they go through the survey, and I'm sure all of you have seen these types of forms, but as you go through them, when the survey team investigates, they must answer every one of the questions that's on the critical element pathway. Their computer system will not let them skip any of the questions. So it's designed to where one surveyor will be the coordinator, and then all surveyors will participate in completing this form. So I would encourage you to go through and look at what questions they're asking, and you'll know exactly what they're going to look at for an infection control survey, which incorporates the Focused Infection Control Survey. One of the things I wanted to focus on is handout number 5. If you're not familiar with this particular document, this is the 26-step survey process and support documentation. CMS provides this particular document to the survey team. This is a 26-step process of how the survey is to be conducted. And I want to just go through with it just briefly. This was updated February 6th, so it's the most current document that's there. As you go through, you notice that steps 1 through 11 are conducted off-site. But this is where, if you look at step number 7, for example, all of the team members are pre-assigned their units before they ever come into the facility. They know what section of the building they have been assigned. They know the residents have been pre-assigned. All of that is done in step 7 of the process. So a tremendous amount of work is completed off-site. So I would look at that. The step 12 provides information on exactly what they're going to ask for during the survey entrance conference, and we will look at some of that. I would encourage you to focus on number 3, which is the initial pool process, and 4, which is the sample selection process. This provides you with the exact guidelines on how they select the residents for the initial pool and for the sample pool. This document is a set of instructions step by step for the survey team. You will have the same information that they have: how to screen the resident, how to select them, even in the sample selection, how to select the sample. Step number 20 completes the facility task assignments. There's 9 of these, and these are pre-assigned before the survey team comes in. They already know which surveyor is going to be in charge of these particular items, and notice one of them is infection control. All of these are completed on every survey, every standard survey. So all of these will be completed. Gets even into how they're going to complete the QAPI program, what they're going to look for and when they will ask for it and what they will look for. So it's tremendous pieces of information and guiding you on what to look for. But I want to show you this particular attachment. This is new. This column has been added. It's the maximum number of complaints and facility reported incident residents that will be assigned to residents in the initial and sample pool process. So if you're between a 70 and 90, and the team survey process, the number of surveyors is not based on your bed size. It's based on the facility census. And in the first 4 or 5 steps of the survey process, they download 6 months of your MDS information, and it's downloaded to their computer system. And from that, they look at the facility census, and that information is downloaded 5 days prior to the survey. And so they know that there's some adjustments when they come in. But so if you're a between 96 and 100 census on the day that they come in, you will have 4 surveyors. But 9, you will have 32 residents in the initial pool. 9 of those residents will come from your complaint and facility reported instance. 21 of those residents will be in the sample pool. So this is a tremendous piece of information here. Appendix B provides information on how they're going to select the sample process. So take some time to look at this document because it provides you with step by step on where that surveyor is going. There still is a focused infection control survey. We're going to look at some of the new components of that. So that document is provided. Also, QSO 20-31, which is a revised COVID survey activities, was updated in January. So be sure and look at that. It contains a lot of information about the focused infection control survey. Handout number 6 is your waived survey tags that Greg talked about. And what we've provided here is a list of the survey tag numbers. The red is being substandard quality of care tags. But Greg talked about that not every component of every regulation is waived. So you'll see that it has an asterisk there. But it just lists all the survey tags. And then in addition to that, the survey tag is broken down by what survey tag number is waived and what component of that regulation is waived. So you'll find this a tremendous help in looking at what particular survey tag number is waived and what part of that survey tag number. And you have a listing of the K tags that are waived as well. So I wanted to just take a few moments and go through what these are, and I think you'll really find it's a tremendous amount of information. Now we're going to go through all of these, So the first thing that we want to look at is the recently added survey numbers. So we look at 48320, binding arbitration agreements. In August of last year, CMS released a new survey tag listing. When we studied that, we noticed that 2 tag numbers had been added. These are tags that once were there, they were removed, and now they have been added back. And it's the binding arbitration agreements. Now, your handout number 2 has the regulations for this. It's my understanding from the current administration that they are going to revisit this. And their intention is to remove this requirement where you cannot have a binding arbitration agreement. The Obama administration had that, been in litigation for years, and it's my understanding that they're going to revisit that. But currently, you have tag numbers 847 and 848 that you need to look at because they are being surveyed. So you want to take a look at that. The next one is your infection control. We've been working with these for several months now, especially with the COVID. F884, which deals with the COVID reporting. F885, notifying residents. We've been following these, but these are new survey tag numbers that we need to focus on. And a copy of these, of course, are in your handouts. I looked at the nursing home compare, or care compare as it's called today. In fact, I looked at it this morning to determine have there been any citations on these 2 tag numbers. And there has not. There's not any recorded through the end of January. So that was interesting, but we probably will see some of those. But currently, there are no F847 or 848 tags in the compare database. So let's look at the revised survey entrance form. This is newly added information to be provided to the survey team. And when we looked at your handouts, notice that information was in red. So let's just take a look at some of that. Immediately upon entrance, when they come in the building, the team coordinator is going to ask for this information immediately. Listing of residents who are confirmed or suspected cases of COVID-19. And you're probably already doing a lot of this already. Especially those who had COVID inspections and those who are undergoing your standard recertification surveys. The name of facility staff responsible for the infection prevention and control program. So that's immediately. At the entrance conference, they want a copy of the updated facility floor plan, especially if you have a COVID-19 unit or where you observe for COVID. So that's a new requirement, asking for the floor plan that identifies that information. Within 1 hour of entrance, a list of key personnel, location, phone numbers, and contract staff. They're probably looking at testing guidance that you've established on that. The names of the staff responsible for notifying all residents, representatives, and families of confirmed or suspected cases. And I'm sure that you've been providing that information. The mechanism used to inform residents. What kind of plan do you have to inform residents of confirmed or suspected cases? How do you do that? The documentation. What actions are you taking by the facility to prevent or reduce the risk of transmission, including if normal operations in the nursing home will be altered? I listened to, and this is under requirement F885. Excuse me. I listened to a Nebraska webinar or session this morning with the state health department. One of the questions that came up during the session was, what kind of plan do you have for those residents and staff who refuse to take the vaccine? What if they say, we're not going to do that? Do you have a plan in place? And one of the participants indicated that the surveyors was asking for that information, and the state health department said, we don't have a requirement for that. That's covered under your current infection control program. Indicated that it might have come from CMS, and it has not. So you might want to just be sure that you take a look at that. Do you have a policy in place on how to address that? And your current infection control program would certainly cover those particular situations. If the system is dependent on the resident or representative to obtain the information themselves, for example, if you provide information on your website every day, we have this many residents, we have this COVID cases, we do this, and they have to go and get that information themselves, what the survey team is looking for is, how do you do that? What type of information do you give to the resident to tell them how to go to the website or where they can find that particular information? Documentation related to COVID-19 testing. And here again, this is newly added information. What they're looking for is this: the facility's testing plan, logs of county level positivity rates, the testing schedule, a list of staff who have confirmed or suspected cases, and if there were testing issues, what kind of documentation do you have in place where you contacted the state or local health departments? This information comes from tag F886. So if you're cited, it will be at F886 for that particular type of information. Within 24 hours, the Infection Prevention and Control Program standards, policies, and procedures to include the surveillance plan. You've had this for years. Procedures to address residents and staff who refuse testing and are unable to be tested. I can attest to this one. I took my first vaccine about a month ago. 10 days after taking the vaccine, I tested positive for COVID. So I've gone through this. I went through all of the processes, did the BAM infusion. I feel great, by the way. But they tell me now that I have to start the vaccine process over again because the BAM process removed all of the COVID protection. They're looking for your antibiotic stewardship program. Another thing that I'm hearing from facilities and listening to some of the state survey agency guidelines is, do you have a policy in place for if the resident or staff took the first vaccine in your facility but has since left your facility prior to taking the second vaccine, what process do you have in place to track that person to be sure that they are getting the second vaccine? So I'm hearing some of that. That's a lot of work to track, and some of you may have already experienced some of that. And do you have a policy and procedure in place that addresses that? So, Greg, do you and Pat, is there anything that you want to address on this new survey entrance conference and the process? Are you hearing anything different?
Yeah, I think it's interesting that, you know, even something that you had heard from some of the healthcare associations in conjunction with the state agencies and discussions is You know, something that you don't often think about, I guess, is because you're in the front lines fighting against this every day. But we basically started COVID-19 and the public health emergency under one administration. Now we're under another. And you know, the former administration, whether or not they were effective in dealing with it, kind of moved towards deregulation more than increased scrutiny and oversight. But the new administration has already spoken about the additional oversight, being a little bit tougher on our industry, and you're going to see some of this filter out through into this process. If you stretch your mind back, if you were in the industry back in 2016 when the requirements of participation were first updated, those two arbitration tags that were added actually had an injunction against them, which is what pulled them out at one point in time. They sort of just appeared. They sort of got slipped back in there almost when no one was looking. So now the information is back in there again. There is some consideration being given during this process, like F884 tags only being cited by CMS if you fail to submit, you know, the NHSN data with the civil money penalties. But the points, you know, the F level deficiency that you receive becomes a matter of record, but the points aren't used in the calculation for your 5-star rating or your SFF risk ranking. So, I mean, while there's things like that, I think one of the things that you had kind of identified with before, Hugh, was a discussion where there was, whether or not you experience this or not, I guess it depends on the relationship with the surveyors as much as the type of surveyors you have in the given area where you live. They were really pushing kind of during this pandemic and the public health emergency to have this collaborative relationship. You know, we're here, it's not so much a gotcha, you know, we're here to kind of help work through this together. What can we do to get your, you know, shore your numbers up, make sure that your practices and your policies and your procedures and your guidelines and everything that you're doing is geared towards reducing or eliminating this. But now that we're kind of starting to see the light at the end of the tunnel and coming out of it, I believe, Hugh, you had heard somewhere where they said, okay, that's going to stop. No more collaborative survey process anymore. It's not our job to tell you, you know, how to run your building or be in compliance. It's our job to basically survey you to see if you are in compliance with the intent of the regulations. And that's going to be a shift.
Yeah, that is correct, Greg. That's a major issue now, where they're saying we cannot survey you and hold you accountable if we're collaborating with you. So that's going to end. In fact, we're going to see. I think one of the things that's caught my attention is by adding the complaints and the facility reported incidents to the survey guide, it's a flag that we are about to see changes, major changes to Chapter 5 of the SOM, which deals with the complaint process. They were in the process of being revised when COVID, the public health emergency, was declared. But my sources tell me that that's about to end, that there will be a new Chapter 5, and we know Chapter 7 is going to be revised. But Chapter 5 is going to have some major changes to the complaint process. So, yes. Thank you for that, Greg. So let's look at the revised infection control
I'm sorry,
pathway.
Hugh, if you don't mind, this is Pat. Before we go further, there were 3, I think, really good questions. So that relate to what you all have just been talking about. So if you don't care, I'd like to go ahead and ask them.
Absolutely.
Okay, the first one was the surveyors want, this was on that entrance conference, the surveyors want a facility-made log of county rates. Is that correct? Why isn't it okay if we just state that they look at the county website for the percent? I think she's just wondering if they need to keep a log, or do they just be able to show them that they can get it available online? What are your thoughts on that one?
I have not heard from any of the sessions that I have heard. That question has not come up. What I think is they would look for is that county positivity rate is published every Monday, and facilities are to be using that to determine what color codes they are in to establish their visitation policies. For example, one of the questions came up was, if I'm using the county test positivity rate guideline, and it was published Monday, and it showed that now I'm in a yellow zone. Do I have to wait 2 weeks from that point to begin my process of implementing the yellow zone guidelines? The answer is no. When that positivity rate chart is released every Monday, it's 2 weeks old. It has 2 weeks of information. So if your county is yellow or green or red, whichever that color is on Monday when it's released, you follow those guidelines. You don't have to wait 2 extra weeks. That time frame has already passed. So because that information is released every week, they may want to know that you look at it. I don't know that anybody downloads the entire database. It's quite large. We look at it every week. I would think that if you had some kind of, that your county is in red, maybe it comes from the local health department. I think what they're looking for is, are you using the county test positivity rates?
So
Yeah,
really, as long as they're able to state them, I think that and tell them where they get them, and that their county is green or their county is yellow this Monday.
Yeah.
Well, and remember
and the survey team, they know that when they come into the building.
Yeah, this is Greg. Don't forget too that the other aspect of the county positivity rates is what you utilize to determine your staff testing. So, what they really want to know is that you've got a methodology to check that. You have to check that regulatorily at least twice a month, right? Usually it's the second and fourth or first and third Monday. I can't remember off the top of my head.
Every first and third Monday. But they release it every week. It's released every Monday.
But that's sort of your dipstick for how the frequency for which you have to test staff, and that's what you look for as part of your infection control practice. Are you looking at that number? So I'm not sure if you have to keep a log, except to be able to validate and prove that you have a system or a process in place to monitor that.
Thank you. Here's another really good question. I feel like this is for residents that have gotten their first dose while they were in the facility, and then if they were discharged prior to getting the second dose. And the question was, is it not the pharmacy's responsibility to follow up with residents that were discharged from the facility to get their second dose of the vaccination? Or is it
based on what I've heard, Pat, from the survey agency that I've listened to their sessions, and that question has come up, it is who provided the vaccine. If the facility provided the vaccine, it's the facilities. But if it's the pharmacy who came into the facility and provided it, it's whoever provided the vaccine. I would make sure that my policy addressed that we're following our policy.
That's a great one. And one of the last question, and then there was a really good comment. The last question, and I think you want to clarify, Greg, you were talking about the infection control citations that do not go towards your 5-star. The question was, did you say that the infection control citations do not go towards your 5-star? I think you probably clarify which tags those are there.
So when the 5-star ratings were unfrozen January 27th, a couple of weeks before that, or a week or so before that, they released the revised technical guide, January 15th, I believe it was. And in the scoring methodology under the healthcare domain or the survey domain, there's actually 2 tags, F-tag 731, which is sort of a waiver related to RN staffing, and the other one is F-tag 884, not 880, the infection control tag, but F-tag 884, which is the tag, one of those new tags that's specifically related to NHSN reporting. It's the tag that only gets cited by CMS, not by a state agency. It's all based on whether or not you submitted your weekly NHSN data. When that tag does get cited, it automatically gets cited at an F-level deficiency, and of course the civil money penalty, which is usually stepped on whatever occurrence this is for you. You could be paying, exponentially more money if you fail to submit. Those 2 tags are not used in the scoring calculation methodology for 5-star, and of course 5-star and SFF scoring methodology matches. So if you get a citation for FTAG 731, or you have gotten more than one citation for FTAG 884, only FTAG 884, the points from those citations, they'll be a matter of public record. They'll still be on Nursing Home Compare, but the points from those citations are not used in your 5-star calculation. In addition to that, one of the other changes made in the scoring methodology is if you received a citation that was corrected through a waiver, or you had a waiver in place, which is still sort of befuddling to me because that's the point of a waiver, is to not be cited. But in seeking clarification from CMS on this, they feel that there may be a surveyor that wants it to be a matter of public record that you are not compliant with the components of this regulatory requirements for this reg, and may choose to cite a tag that is covered under a waiver. While that again will become matter of public record, you will not get the points from the scope and severity of that tag added into the calculation. So if you get a citation that you have a waiver in place for, it just becomes a matter of public record. No points from that citation go into your calculation. And if you get 884 or 731, that's hands down blanket, no points go into your calculation for that.
And then one final thing, there was a really good comment that I think is really pertinent for everybody in the state of Massachusetts. And it says in that state that we are required, or they're required to test all their staff weekly, regardless of the county positivity rate. So I just wanted to make sure that that was brought out, and I thought that was a great, so thank you for the person that sent that to us.
Yeah, that is a great point, and that's one of the reasons in our software when we publish the positivity rates is, the rule of thumb is always that you adhere to whatever the most stringent guideline is. So if your state has a more stringent policy or procedure than the federal guideline, well, that's what you have to adhere to. Conversely, if your state says, well, you can test whatever you want, but the federal says you have to follow this, and that's the more rigid, then that's what you have to adhere to. So whichever guideline is the most rigid or restrictive, I should say, that's the one you're required to adopt.
Okay.
Thanks, guys.
Move to the infection control. I think some of that will be addressed in this particular component for surveys beginning after November the 30th. The probes for the focused infection survey tool have been combined. We've talked about that. So you've only got one infection control pathway. Surveyors are to use the revised pathway for all long-term care recertification surveys, infection control complaints, and the focused infection control standalone surveys. They still exist. We'll look at that. And this is what Greg just talked about. The facility task is now used to investigate compliance at F80, 81, 82, 83, 85, and 86. Notice 84 is missing because that's only cited by CMS. State survey agencies cannot cite F884. F884 is used to determine the focused infection control survey. Surveyors conducting the COVID focused infection control not associated with the recertification survey must evaluate the compliance on all critical elements with exceptions of number 8 and 9, and that deals with laundry and antibiotic stewardship program. They must also examine the facility's compliance at 48373B6 or E0024, and those regulations deal with policies and procedures for volunteers. So make sure that you have those in place because they will look at that. Each surveyor is responsible for assessing the facility for breaks in infection control throughout the survey. So let's look at what one will do just quickly. One surveyor will perform or coordinate the facility task to review for standard and transmission-based precautions. This is in every recertification, focused infection control, complaint survey. They will look at these items: resident care for COVID-19, infection prevention and control program policies and procedures, infection surveillance, and you already do these things. Visitor entry, you already have policies and procedures on how you're going to test visitors. Education, monitoring, and screening of staff. Staff and resident COVID-19 testing, what are your policies on that? Are you going to make it mandatory or not? suspected or confirmed COVID reporting to resident representatives and families. How do you do that? Laundry services, key element, antibiotic stewardship program, your infection preventionist, and it's my understanding that the current administration is really going to take a revisit this and put this back in as a major requirement of the infection control. Influenza and pneumococcal immunizations. So this is what the surveyors are instructed to sample residents and staff as follows. Now, this information is contained in that critical element pathway. Sample 3 staff. And these are the requirements included. 1 staff member is confirmed or positive has signs and symptoms. Sample 3 residents for the purposes of determining compliance with infection prevention. Include at least 1 resident who was confirmed or had signs or symptoms, if there are any. If there's not any, it's not an issue. And include at least 1 resident on transmission-based precautions for any reason other than COVID. So this is what your sample residents are going to look at. To go back and remember that chart I showed you with the number of initial pool residents and sample, these are the sample residents. So they're going to 3 staff members, 3 residents, and 5 residents for influenza and pneumococcal immunization. So that's part of the new survey process as far as the critical element pathways. Greg mentioned resuming the long-term care survey process. And because the cases, COVID cases, are on the decline, which is great news, they are no longer focusing on the focused infection control survey. They are now looking at resuming the standard health survey. And it's my understanding the way from some of the survey agencies that I've talked with, what they're doing is not necessarily the priority is those who have not had a survey within the past 15 months. But that's not the only criteria. They're mixing it to go back to the standard recertification survey as well as emergency preparedness surveys. At least 1 resident who is suspected or confirmed positive will be included in the initial pool process. Facilities must permit surveyors, including emergency preparedness and life safety code surveyors, into the facility. They must wear appropriate personal protective equipment, and they're supposed to provide it, and adhere to any health-related screening protocols before entering the facility. If you require all visitors, all vendors, anyone coming in your facility to go through a screening protocol, take their temperature, check for signs and symptoms, you can still do that. That's part of your protocol, and the surveyor must adhere to that. You cannot require testing or proof of testing as a condition. The surveyor does not have to provide you with anything other than I've been tested. And listening to the state of Nebraska, they do not provide any information to the facility. Their rationale is we test our surveyors weekly. If a surveyor comes to your building, they have been cleared. So they don't have to provide you of any type of proof. Now, your state may be different. The survey team should minimize the number of surveyors who interact with known COVID-19 positive residents. COVID-19 units will be included in the sample selection process. And it's my understanding the way they're going to do that is that if you have COVID residents or if you have a designated area for COVID, 1 surveyor will be assigned to the COVID unit or to survey COVID residents. They will not be permitted to intermingle with any of the other survey team once they enter that part of the building. All of the interviews, all of everything that they will do with that surveyor will be virtual, but that surveyor will not be permitted to interact with any of the other survey team members once they enter that part of the building. So you may want to really observe for that when they're in your building. During a standard recertification survey, initial pool interviews will be conducted in person because this person is going to be assigned to that, even if the resident is COVID positive. So the standard survey, the re-implementation of that is not going to eliminate the COVID survey process at all. The exit conference may be conducted by phone if all invited parties agree. So let's look at the new trigger conditions for a focused infection control survey. So these are the new things. Greg talked about F884. F884 is used by the state survey agency. How that works is every week the information is sent to CMS. CMS on Mondays reviews that data. They send a listing to the state survey agency within 3 to 5 days of any facility that meets the focused infection control survey. For example, if you've had 3 or more new cases within a week or an initial case, they send that information to the state survey agency. Within 3 to 5 days of the state survey agency getting that information, they are to conduct a live survey, come to your building to conduct the focused infection control survey. That information comes from tag F884. But here's some new additional criteria. Multiple weeks with new COVID cases. That comes from your county and your NHSN weekly reporting. Low staffing. Selection as a special focus facility. That listing was released. It's released every month, and it was released today. Concerns related to conducting outbreak testing per CMS requirements. Greg talked about how the deficiencies are cited for your infection control. If it's an F or higher, you're going to be surveyed, and in some cases it's D or higher. That QSO memo 20-31 gives you the exact guideline of how and what scope and severity levels you will receive and what the penalties are. Allegations of complaints which pose a risk for harm or immediate jeopardy to the health or safety of residents, which is related to abuse. And surveyors are instructed to be alert to and investigate any concerns related to residents who have had a significant decline in their condition, weight loss, mobility during the public health emergency. So you want to really take a look at those new guidelines. 20-31 will provide you with tremendous information about that. Waived survey tags. Greg mentioned this in detail. The waiver requirements became effective March 1st, 2020. The current public health emergency is scheduled to expire April 21st. I believe that's correct, April 21st. There may be a possibility that it will be extended. The trend now is that long-term care facilities are doing better than the general public. So there may be some limited extensions. There may be some removal of some of the survey tags that's under the waiver. There are currently 36 F tags that are waived as a result of the public health emergency. That listing is provided in your handout. There are currently 10 K tags that are waived. Not all components of the survey tag may be waived. The staffing data submission waiver ended June 25th. So when you're looking at the waived tags, study that document to make sure that you're really looking at what part of the regulation is waived. And Greg mentioned this. Waivers do not mean that citations will not be issued. Does not mean that at all. It merely means that that information will not be counted in your health inspection scores. So it'll show up on your nursing home compare. I'm sure you'll have to do a plan of correction. It doesn't mean that the citation will not be issued, and not all parts of that tag number is waived. So, Greg, you and Pat have anything that you want to add to that? I know we covered a lot of information. Those were some great questions. So I will turn it back over to you guys. And
this is Pat. Let me go ahead and ask a couple of questions. And then, Greg, I think you've got a couple of good comments that you would like to add. But the two really good questions that have come in just recently is, where can we see the list for special focus facilities?
I can provide them that list, or Team TSI provides it, okay. I believe.
And we can probably provide that list to them. And
it was released today.
Yeah, CMS releases the list. If you actually just do a Google for SFF list or special focus facility list, it'll take you almost directly to it.
Okay. And then the other was a question, and this relates to the multiple weeks of new COVID cases triggering that infection control survey. When you have multiple weeks of new COVID triggering the infection control, is this for residents only, or does that multiple weeks include staff as well?
I would say that it's residents, because you're reporting, I think it's more residents than it would be staff.
Okay. Yeah, I agree. I think that's basically when they're looking at 3 or more positive cases or your first new case, it's measured against residents, not staff.
Yes.
I mean, they're all resident-centric kind of measures. I believe, we're doing some stuff with, the waivers in and of themselves. Remember that 1135 waivers endure for the duration of the public health emergency. When the public health emergency ends, the waiver ends. So, other elements that may not even be regulatory, things like the 3-day hospital waiver to put somebody on Medicare, they're all still in effect. But when the public health emergency ends, those waivers end as well. Even the enhanced enforcement remedies, in response to your prior citation history for infection control tags, where you can get additional either some money penalties, you can get a shorter time frames for correction of the deficiencies based on the frequency with which you've been cited or the scope and severity with which you've been cited in the past. That's all attached to the public health emergency, and it explains that at the end of the QSO letter as well. So, all of that fun, that goes along with it. And there's always been this sort of media portrayed message out there that, our industry was basically caught with its pants down. We just weren't prepared for this to happen. And it's kind of it's become a media narrative, but I don't believe that it's accurate. We can go all the way back to the requirements of participation changing, or in 2016, that started with the infection control preventionist, the infection control surveillance officer, antibiotic stewardship. Infection control has been at the forefront and focus of our industry for many years. This is a worldwide pandemic. This did not just affect the long-term care industry. If it had, then maybe you could say that. But this impacted the entire global population. And I think it's a little unfair, and it becomes a little bit of a finger pointing almost to say, who can we blame? Who can we blame for this? Had a significant impact on the 65 and over population. And of course, who could have prepared for this? So I think it's unfortunate that we're under that level of scrutiny and oversight, and that's been the media presented message. But you guys are on the front lines facing it every day. You're kind of out there fighting the good fight. You're going to be facing a challenging year. We've seen the erosion in occupancy, which, correspondingly has an erosion in revenue. The challenges faced from a staffing standpoint, the need to pay premiums to get people to work, or the premiums that are being transferred across from agency. It's going to be a challenging year. And if we're facing that with a promise of even more regulatory scrutiny and oversight. Well, I just want to make sure that I thank everybody on this call for everything that they do, and each and every day on the front lines, facing this, because none of this gets done, and this population is a vulnerable population without all of you. So I just wanted to basically say thank you for everyone. Having been in the industry as long as I have, as well as Pat and Hugh, we all feel the same way. Just very appreciative for everything everyone does.
Absolutely.
We sure do, Greg.
And
I
guys,
appreciate all that they do. Just one thing I would add is to remind you is that 20% of all surveys for 2021 and 2022, 20% of all surveys will be focused infection control surveys. So we can't drop our guard when the public health emergency ends. 20% of all surveys will still be focused infection control. Thank you for allowing me to be a part of this today.
Hugh, there's one more question, and Hugh or Greg, and I believe we have this, or it may be part of the handouts, but is there written guidance or documentation about the CMS routine testing for staff, where if a county is yellow, then the center can test once a week upon that week's posted status? They had always heard it has to be 2 weeks of yellow.
I believe it's QSO memo 20, it's either 20-37 or 20-39 provides that information. If you're in a green zone, it's once a month. If you're in a yellow, it's every 2 weeks. If you're in a red, and it goes by the color, not the percentage rate. CMS changed that. So you're focused on the color, not the percentage rate.
And the other focus of that is if you're in green and you're testing once a month, wonderful. If you move to yellow, the minute you know your county's in yellow, you immediately must begin testing at the higher rate, which is going to be weekly. If, however, you are in yellow testing weekly and you move to green, you must continue to test weekly at the yellow level for 2 more weeks before you can drop back down to the green and the reduced testing. That's the guidance.
The only exception to that, Greg, is if they're using the county test positivity rate because it's already 2 weeks old.
Oh, yep, you're right. Yep. I hope that answered the question.
I believe it answered, and there are no other questions, so.
All right, well, thank you, everybody. I think we can conclude our webinar. This was wonderful. Thank you, Pat. Thank you, Greg. Thank you, Hugh. This was amazing. We're getting some wonderful feedback and a lot of emails coming in. For those of you that aren't sure, yes, we are absolutely going to send the recording out in the follow-up email along with those handouts. So again, thank you for taking the time to attend our training, and thank you so much, Hugh, for the preparation of this wonderful presentation.
Thank you.
All right. Bye-bye, everyone.
Bye-bye.
Bye. Thank you.